Good afternoon. Well done, you're still here. Thank you very much for the invite to come and present. This is what we hope to cover. It's a short 20-minute session. A little think around the extent of the problem of surgical site infections, the risk factors that are relevant, and we're thinking in particular about vascular patients. Obviously, I'm a vascular nurse practitioner. We're going to have a little look at the latest recommendations that have come out from the National Wound Care Strategy programme around surgical site infections. And just to finish off, a quick look at the research that's informing our practice currently. So wound closure, as you're probably aware, the main method, most surgical wounds will be closed by primary wound closure. Healing by primary intention. Edges are drawn together with either sutures or staples, sometimes glue. And that's in place for anything up to 7 to 14 days, perhaps slightly longer. And that depends very much on the anatomical location of the wound and the closure material that's used. Some wounds, as you can see from this diabetic foot wound, are left open deliberately. That's secondary intention of healing. So this patient's undergone a ray amputation of the second toe with the metatarsal head removal for infection. The concern over latent infection embedded within the tissue means that we're hesitant to shut that by primary closure. We don't want to lock infection into the foot itself. So we leave it open for management by healing by secondary intention. And of course, there's wounds that are sometimes closed by delayed primary closure. So they may be left open for further debridement or drainage and then finally closed. That's perhaps more common in orthopedics than it is to vascular. And if we just take a moment to think about the normal stages of wound healing usually takes place in a very structured fashion. You get the inflammatory phase where inflammatory cells migrate to clean the wound. So they remove the debris and they clean that wound. And in that stage, it's quite normal to see some redness and inflammation around the suture line itself. And that can last for anything up to 2 to 7 days. We advise patients that this is normal and not to be concerned. It should settle. Once the wound is clean, we move on to the proliferation stage. So the wound starts to begin to repair itself, and it starts to heal from the wound base up. It starts to contract at the edges, and we get that new skin that covers the surgical wound, that epithelialization. And that can take place anything from 4 days to 3 weeks. And that final stage of wound healing is a much longer stage. It's the maturation stage. And that's when new tissue gains strength and flexibility, and it can last for anything up to 2 years. In this stage, we often recommend to our patients to apply emollients to that surgical site to keep it moisturized, to prevent drying out, and to promote the good integrity of the skin going forward. But we're here to talk about surgical site infections. Sometimes wound healing does not go according to plan. Patients may develop surgical wound complications. So what is a surgical wound complication? It's a disruption to the normal healing of a surgical wound. In the UK, there's an increasing number of patients undergoing operations. These patients are increasing in age. We have an aging population. So they come along with excessive comorbidities often and very complex surgery. There's around 10 million surgical wounds that are created each year. 21% or 1/5 of those fail to heal in a timely fashion. So there's 1/5 of patients who go on to take up to a year for that surgical site to heal. And it has a huge impact on patients' morbidity. Not only affects their quality of life, but it can be potentially life-threatening. Mortality affects about 1 to 4% of patients as a result of a non-healing surgical wound. It's not only a burden on the patients themselves, it's also a burden on community services. Since COVID, there's been a huge push for daycare surgery, so patients in and out in a very short time frame. The operation indeed does take place in secondary care, but it's often handed over to primary care and community nurses then for that further ongoing management, placing huge burden on community services. Many of these surgical site infections and surgical wound complications are preventable, and we're going to think about how we can do that as we go through the presentation. And out of all the surgical wound complications, surgical site infections are among the most common. They often lead to surgical wound dehiscence, which is recognised as a surgical site infection. But we can also have that without infection, so you can have dehiscence without infection as well. So surgical site infections are post-surgery infections that can affect the incision or the deep tissue at the operation site, and they're categorised according to where they affect. You can have that superficial incisional infection, which occurs in the skin and subcutaneous tissue, causes pain, swelling, heat, and localised redness. Sometimes can be purulent drainage, but not always, and the patient's sometimes not on well with this local infection. And that often happens anything between 7 to 9 days when it's most commonly reported, but it can happen up to 30 days from that surgery. If the patient has an implant, it can happen up to a year. It can still be classified as a superficial incisional infection. Your deep or your open incisional infections, they lie within the fascial and the muscle layers, so they're not quite so superficial. You accompany the same issues: pain, swelling, heat, redness, and again, purulent drainage. In these infections, you get that separation often at the edges of the incision, so you start to get wound dehiscence, which begins to show you the layers of muscle and fascia underneath. They're often classified within 30 to 90 days of appearance. And then we have that final categorization of the open space incisional infections, and that's infection within 30 to 90 days of the procedure. It involves any part of the anatomy other than the incision itself. It's usually accompanied by positive blood cultures, deep tissue biopsies, and these patients are often very unwell. Early diagnosis of these surgical site infections is key. We want to avoid further deterioration, we want to avoid long-term complications, and of course it should be made on the clinical signs and symptoms that accompany the infection. And there's a few challenges around the suboptimal management of surgical site infections. It seems to be that there's an unwarranted variation in care of wounds in the community in general. We know that from lower limb ulceration, and we know it from wounds in general. So the management of wounds is subject to variation and not always to structured pathways, and it's no different for surgical site infections. These infections are often left within the care of our community colleagues. They don't always have any great backup from the surgeons or the surgical team that initiated the surgery in the first place. There seems to be an underuse of evidence-based practice and an overuse of non-evidence-based practice. And perhaps most importantly, we don't have a handle on the actual scope of the problem. Surgical site infections and SSIs are a hidden but growing problem. Orthopedics mandate follow-up for their surgical site infections. We don't do that in vascular. So we may see them a little bit further down the line with quite extensive complications, but we don't have a handle on the actual quantity of surgical site infections currently. So what are our risk factors for surgical site infections? So if we look at our main risk factors first of all, and you'll notice that some of these are in red. So our typical vascular patients are a challenging lot. They tend to be older, majority of them are male, they have many comorbidities such as diabetes, COPD, cardiac failure, ischemic heart disease, and by nature of the disease they have peripheral arterial disease. So vascular surgery in itself is associated with high rates of SSI because of the nature of the patients. Perhaps one of the most beneficial things we can do is start to screen these patients adequately. So those high-risk patients, of which vascular patients on the whole will fall under that category, we need to screen them and we need to try and think of strategies that we can do to lower the risk of SSIs. There's the SSIRS surgical site infection risk score, which can be used. You can use tables such as this to try and screen patients and optimize the outcomes for this cohort of patients. This is a very typical vascular patient, so thinking about moving on to think particularly why are vascular patients so challenging. So surgical site infections affect up to 40% of vascular surgical procedures, quite high numbers. And there's multiple reasons for that as we've talked. We've got a high-risk patient group to start with. We've also got patients that come with tissue loss already to their foot prior to surgery. High risk for infection. For our patients in vascular, we know that SSIs are distressing for all patients, causing pain, reduced mobility, extended hospital stays, and scarring. For our vascular patients, it increases their risk of losing a limb. They're twice as likely to die in the post-operative period if they develop an SSI than those that don't. It's really important that we can minimize our occurrence of SSI. Have a look at this limb. This is a gentleman I know. He's a frail gentleman. He's elderly. He's a farmer, and he's still farming despite his ischemic ulcer. He's got lots of comorbidities. He's diabetic. He's got heart failure, chronic kidney disease, and we need to revascularize this leg. So we need to do a graft. We need to do a bypass operation. We need to save his limb, and that's going to involve further extensive surgery. The groin is the most common site for an incision in vascular surgery. It provides access to the femoral vessels, which we often hang a graft on while we take it down, lower down the leg to reperfuse the lower limb. It's a high predisposition to surgical site infections. This type of skin flora, which resides in the groin, makes it very difficult to avoid infection. There's difficulties in decontaminating that area. You're very close to the anal canal and the genital area. This gentleman also has an open ulcer, which he's had for months. That's going to be growing lots of bacteria. It's a high risk for infection. He's got leg edema because he's hanging his leg out of bed for rest pain. That's another high risk for infection. We've got inflammation going on within the tissues of that leg itself. We need to put a long length of bypass into that leg to go past the blockage. We're going to avoid using plastic prosthetic graft because that's a high risk of infection. We're going to look for a vein, which is going to have higher patency rates and lower risk of SSI. There's lots of things that make this gentleman high risk. So what strategies can we use to try and minimize a poor outcome for this gentleman? If you look around the area, there's lots of advice, isn't there? You can read huge volumes of advice around this area. We've got the World Health Organization doing the right thing at the right time to stop SSI, and that gives us lots of detail for specific evidence-based interventions, from planning to post-operative. I'm not a theatre nurse. I don't get involved in that side of things. I'm involved in the wound care side of things. We've got our NICE recommendations. NICE 125 focuses on methods used before and after surgery to minimize our risk of infection. It's given us some recent updates, recommendations on nasal decolonization, antiseptic skin preparation, the good use of prophylactic antibiotic therapy, and methods of wound closure that are best used to minimize SSI. So we can use that to help guide our pre and peri and post-operative period. There's well-organised surveillance programs, including feedback for infection rates to surgeons. When they take place, they're associated with significant reductions in SSIs. So just by surveying our outcome rates, they immediately improve. Unfortunately, we're not yet doing that for vascular surgery. But most recently, we've had the National Wound Care Strategy Programme, and they've given us some great advice and great recommendations, and we're going to have a little look at those now. So if we think of the pre-operative stage, let's do it stage by stage. So the pre-operative stage, what does the National Wound Care Strategy Programme recommend that we do to reduce our risk of SSI? Well, they say, first of all, identify those at high risk. Who are these patients? For us, vascular patients, they're nearly all high risk. If they've got a BMI higher than 35 and we're going into a groin for a second time, they're very high risk. Think about enhanced recovery after surgery programs. So that multidisciplinary approach to a patient, their pathway, altering the things that we can alter. How can we reduce their smoking? Can we optimize their nutrition? All of those things that are going to enhance recovery. But there's a problem with vascular patients because a lot of the surgery is urgent. We don't have that window of opportunity. These patients come in with a critical limb. We've got 5 days or 2 days or 3 days to operate and save a limb. Perioperatively, we can consider using a perioperative pathway. So again, that's looking at the patient as a whole. that's making decisions along with the patient that's going to optimise. And they make some specific recommendations. It's really worth a look if you haven't read that. It's really worth a look at what we can do in detail to reduce the risk of SSI. What about during operation? What can we do to reduce our risk of SSI? They recommend considering capturing a digital image in the operation of that surgical site. Any of you here nurses or theatre nurses? Do you do this in practice? So it's difficult, isn't it? It's a recommendation from the National Wound Care Strategy Programme that we should be taking a digital image, a baseline image of that wound. I would say it's probably more effective and perhaps easier to do is to take it on just before discharge, so we can hand that over, and we'll talk about that shortly. Cover the incision with an appropriate waterproof dressing. Well, what's appropriate waterproof dressing? What's our evidence base? It's not a huge evidence base for waterproof dressings. For our patients with surgical site infections, we do have a recommendation from NICE, and that's to use Leukomed Sorbact as an appropriate waterproof dressing. Consider incisional negative pressure wound therapy for high-risk patients. Should we put a PICO dressing or something similar onto that wound? And if you notice, it's consider. These are not definite recommendations. There's a lack of evidence here for all of this. Consider topical negative wound therapy for wounds closed by secondary intention. That's probably been a bit blown out the window now with the SWISH 2 results. What can we do post-operatively? Well, they recommend our low-risk patients. Surgical wounds are closed with sutures, clips, or glue. We're not expecting any difficulties with these patients. Then we can support them to manage the wound themselves. We can take a photo before they leave. We can pass that information on to the community nurses, and we can empower the patients to look after this themselves with perhaps something like a wound care passport to hand to them to go out of hospital with, to give them advice and guidance. What are high-risk patients with surgical wounds that are closed? So we expect them to heal, but they are a high-risk patient. So we're going to enhance the care available to that patient. I'm going to either put them with Leukomed Sorbact as the secondary, as the dressing, covering their surgical site infection, or I may put them on topical negative wound therapy to cover that. We'll give them early review by the vascular nurse so they've got access back into the service very promptly. And what about our high-risk patients? Consider topical negative wound therapy? Not anymore. Unfortunately, that's really been blown out the window with the SWISH 2 results. But you're going to have to manage that wound. You're going to have to use appropriate dressings to manage exudate while that wound heals by secondary intentions. Sometimes it may be that topical negative wound therapy is the correct thing for that patient regardless of that, but there are other dressings available that may do that also. Our local dressing initiatives to reduce SSIs. So we follow a pathway where we categorise the patients, those who are slightly lower risk, they go for Leukomed Sorbact as their dressing following surgery, and those with high BMI, morbidly obese, or redo groin get a topical negative wound therapy put in place. Do we have a huge body of evidence to support this? We have a small body of evidence, but there's work ongoing, and hopefully that will be accumulating as things develop. So our local initiatives to reduce our SSIs, these are the things that we do in practice. We offer them early review by a vascular nurse specialist. Any concerns, they've got a contact number, they've got access to a hot clinic. Hot clinics are usually for critical limbs, but we also offer a hot clinic for a wound review. They've got a point of contact for patients, and the community nurses have a point of contact to access the service again. We offer patients a wound passport on discharge, so they can have a wound passport which outlines what that's been closed with, when the sutures should be removed, if they're going to dissolve, when they can have a shower, when the dressings need changed, signs and symptoms to look out for. So it's empowering that patient to keep an eye on this, and it's also allowing the nurses to understand what they would expect, when the sutures should be removed, etc. The other thing that we use in Cumbria is that Healthy IO, which is digital imaging. So this is a really useful bit of kit. It's an app that we have on iPhones, what we take photos with on discharge. We take photos in the ward round, and that's uploaded to share across with our community colleagues. So if a nurse phone's concerned, I can have a look in Healthy IO, I can scan the wound, and we can have a discussion should there be anything done further. It allows us to monitor treatment, allows us to share across disciplines, and it facilitates that expert opinion. And of course, the other thing we're very hot on is that being involved in research. One of the things we're often asked is when should we initiate antibiotic therapy? Systemic signs and symptoms are what guides that decision. If there's erythema greater than 5 centimetres from the incision within duration of necrosis, we absolutely should be thinking about antibiotic therapy. What should we use? I have a discussion with the local microbiology. These patients have had multiple doses of antibiotic therapy because of chronic wounds, as well as implantations of devices. So I have a discussion with microbiology before we make a decision what these patients should go on. Antimicrobial stewardships, I have to just mention this. It's those simple things. The hand hygiene, we forget to tell patients what they ought to do. We forget to remind clinicians to wash their hands before they touch patients, wash their hands after they've touched patients. Those simple measures that are so elementary that they're almost forgotten sometimes. Using topical antimicrobial dressings, and we've talked about that. Leukomed is a topical antimicrobial. It's a DAC dressing. It does provide some barrier to antimicrobial action. And of course, monitoring patients' home environment. I don't have that privilege, but the community nurses are very hot on keeping an eye on patients' home environments. We can't change that, but it may mean that we keep addressing on a little bit longer depending on the home environment. Just to finish off, quick research to inform practice. There's lots of things that we're involved in. The GIVE study has benchmarked SSI rates and provide a platform for future randomised trials. The SWISH, I've alluded to this already, no evidence that a negative pressure wound therapy improves secondary healing. And we're currently recruiting to a dressing trial, which is looking at Leukomed Sorbact as opposed to normal dressings as part of a randomised controlled trial. So are these dressings really effective in preventing surgical site infection? We'll know the outcome to this, hopefully, when this is finished. So thank you very much for your attention. In conclusion, really, I just want to say SSIs are really costly. There's unwarranted variation in the care that we provide for SSIs. And I think one of the first things we ought to be doing is how we can embed surveillance. And for me, this is a problem for vascular, but how can we embed that into our practice? Because by doing that alone and highlighting the rate, we will naturally start to reduce SSIs without changing anything else. Thank you very much.